Welcome to the Western Virginia EMS 2025 protocol rollout. I'm Dr. LaPera.
Greetings. I am Brian Alderson.
I'm Dr. Stanley.
I'm Dr. Green.
And I'm Dr. Icky.
As always, the first step with the new protocols will be to update your app. So check the App Store, make sure that you have the newest version. Once you've downloaded that, click on and choose the 2025 version.
The 2024 version will still be available in the app for you to use until you are cleared by your agency for 2025.
Today we'll start with some drug box updates, and then we'll review some EMT updates.
Later we'll cover updates for AEMTs and above, and finish with some critical care news.
As expected, the state has mandated we retire the regional Big Orange drug box.
So, for now, we're moving in the protocols to a recommended formulary list.
The recommended formulary is linked below and also in the app here on page 114.
The recommended formulary list is all of the medications that are used in these protocols. Agencies are encouraged to use this list as a starting point for developing their own drug kits. The quantities listed are minimums per patient, so agencies may elect to carry more medications to suit their needs.
The second page of the formulary also contains a list of optional meds, and also all the medications for critical care.
This new system is still developing, so watch for more updates from the Council.
Okay, let's begin with EMT updates, which comprise about half of the 2025 changes.
We will also review all the specific VA OEMS red dot skills in the WVEMS protocols.
This will help us maintain compliance with current Virginia Office of EMS regulations.
No big changes to number 4, airway, for 2025. The BIAD remains the primary airway for resuscitation.
And Western Virginia EMS prefers the iGel.
BIAD is an OEMS red dot skill, so if you have any questions or you're a new provider, contact your training officer.
There is an update to the small text to remind providers to sit patients up.
By sitting a patient more upright, this can help reduce aspiration risk,
especially with patients that are semi-conscious or completely obtunded.
There are no big changes in number 6, breathing.
But recall, non-invasive positive pressure ventilation includes CPAP and BiPAP and remains an important component of ventilation.
The indications have been slightly expanded for 2025. It is now appropriate to try non-invasive positive pressure ventilation on those patients that are less responsive.
Make sure that you are monitoring these patients closely and remove it promptly if the patient has any vomiting.
NIPPV is also an OEMS red dot skill, so if you have any questions or you're a new provider, contact your training officer.
Capnography also remains an important adjunct to diagnose and treat respiratory complications.
For 2025, the entire book has been standardized, and all end-tidal CO2 targets are now 35 to 45 for all indications.
CAPNO is also an OEMS red dot skill, so if you have any questions or you're a new provider, contact your training officer.
For number 20, our pain protocol, we have some exciting new changes. The work group, though, again wants to stress the basics and to emphasize the benefit of giving oral pain medicines.
All providers are encouraged to consider some kind of pain control, even if it's oral and even if it's close to the emergency department.
The evidence-based guidelines are linked in the references section.
New for 2025, tetracaine eye drops have been added as an optional medication on the formulary for eye pain.
These tetracaine eye drops can numb the surface of the eye, and this is especially useful if a patient has a corneal abrasion or a scrape to their eye or a welder's flash burn.
Do not use tetracaine if you suspect penetrating injury.
The dose is 1 to 2 drops in the affected eye, and it's also the same for adults and pediatric patients. Use caution with refusals after tetracaine. Patients really should have an eye exam.
Another new and exciting addition for AEMTs in 2025 is the optional formulary IV Tylenol.
Your agency may decide to start carrying IV Tylenol for pain and fever control.
Doses for Tylenol and ibuprofen have been increased to prescription strength single doses.
This way, the dose is the same for IV Tylenol and PO Tylenol.
It comes pre-mixed in a bag, and providers should give it as a drip over 10 minutes.
Just a quick update to number 28 chest pain. The preferred nomenclature is now STEMI alert. It was previously heart alert. This was a request from the Virginia Heart Attack Coalition, who helped us develop the STEMI protocol in critical care.
The actual patient and EKG criteria have not changed.
It's only a change in name of the alert. Protocol 40, overdose and tox.
One of our first big concept changes in 2025 is in our overdose and toxicology protocol.
Providers will find Narcan and normal saline bolus remain here for the typical consideration. but all the other antidotes are moved to a bigger table in the Administer Antidote procedure. The work group wanted to expand the antidote table well beyond the few indications we had in 2024.
Providers can consult the table in the back for more exotic antidotes. A few new meds are listed here, including charcoal, cyanokit, duodote, and thiamine.
If you look at the antidote table, bolded indications are our typical standing orders.
But the rest of the antidotes and the indications are online orders only.
Providers are encouraged to contact poison control if they suspect significant toxicity.
And providers may take online orders from the toxicologist at Poison Control, or call the ED or your OMD for orders.
Another significant change for 2025 is the removal of the crush injury protocol.
Regional utilization was very low, and it was almost a direct copy of number 18, hyperkalemia.
So the protocols still include treatment of crush injury, but it just now appears here as small text in number 66, extremity injury.
Just a few little updates in our cold and heat exposure protocol.
Warmed oxygen has been added to the active warming measures, and PO fluids were added to the active cooling measures.
Frostbite was also moved into the small text. Ibuprofen was added for prophylactic treatment of frostbite.
Current treatment guidelines suggest that NSAIDs improve outcomes in frostbite.
There is no specific update in number 76, epistaxis, but there is now a table of common anticoagulant blood thinners for your reference.
You'll notice this includes direct oral anticoagulants and antiplatelet medications.
Both the trade name and the generic names for all of these medications are listed, and there are quite a few. This may be useful for reference from other protocols as well, such as major trauma or head injury, when it's important to know if the patient is on an anticoagulant.
Providers will note that some procedures have been moved around to accommodate the new antidote table on page 100.
In 98 bleeding procedures, the workgroup wanted to allow for more exotic bleeding control devices.
Agencies may now elect to try some of these purpose-made devices with OMD approval.
There has been some significant advances made with junctional tourniquets.
And with novel devices such as the IT clamp and XStat.
Agency OMDs must approve any of these devices before they can be used.
Protocol 109, cardiac devices.
The LVAD policy was renamed and expanded to include other advanced cardiac devices,
like the Zoll Life Vest and intra-aortic balloon pumps and transvenous pacers.
Providers are encouraged to bring all equipment and batteries to the ED.
Please take special note. If you are transporting a patient that requires batteries for their device, please ensure they bring them. Providers may also consider the advice of the patient or trained bystanders. Many patients with these advanced devices will be very well versed in the maintenance of their devices.
Please do not unplug or try to change the programming or remove any of these devices.
Some of the devices will actually talk to you and provide some guidance, so don't let that surprise you.
Please recognize that active management of any of these cardiac devices is outside the scope of EMS.
Danville and Martinsville-Soville hospitals are now certified stroke centers. Consider preferential transport to a stroke center for any VAN-positive patient.
And now for a few updates for the AEMTs and above.
Other BLS providers, feel free to skip ahead.
So for 2025, there is a big concept update in our circulation and shock protocol. There was some concern in the region about having our bolus dosing for IV fluids at a full liter, and sometimes the protocols were a little bit inconsistent.
So now for 2025, all adult fluid boluses are 500 ml for all protocols.
You can give this up to 4 times, so our maximum dose is still 2 liters for adults.
Pediatric fluid bolus remains unchanged at 20 ml per kilo per bolus with a max of 60.
For agencies that want to stock 500 ml bags, we've also included alternative mixing instructions for the dirty EpiDrip.
Instead of the full milligram, you simply place half a milligram in the 500 ml bag. The concentration and dosing rate remain the same.
Agencies may also notice that dopamine was moved to the optional formulary, so you may notice there's some declining availability of dopamine. Another big concept update is basically the oldest unsolved question in EMS.
Experienced providers will likely have been through this a few times already.
For number 24, our medical code, we are going back to amiodarone.
The dosing of this medication is slightly easier, and there are no weight-based exceptions.
The pediatric dosing is also slightly simpler, and the PEDS reference in the back has been updated.
Lidocaine is now on the optional formulary, so agencies could still discuss custom exceptions with their OMDs.
In number 30, dyspnea, the dose of decadrone has been increased to 10 milligrams.
This was purely a logistical decision. Either 8 milligrams or 10 milligrams are acceptable doses.
So agencies may choose to continue with 8 milligrams if that's easier for them to source. The drug monograph in the back lists 8 milligrams as the acceptable substitute.
Providers may also remember that magnesium was removed from the AEMT scope by Virginia Office of EMS in 2023.
We continue to discuss this with the state, but for now, we are continuing with EpiNebs, which is an OEMS red dot skill for AEMTs.
Remember, our EpiNebs are especially useful for any adult in extremis, such as anaphylaxis, or in pediatric patients, especially with croup or asthma.
Can also use a T-piece valve adapter to give it inline with non-invasive positive pressure ventilation.
In our diabetic protocol, the normal saline bolus for hyperglycemia is now adults only.
Fluid boluses in hyperglycemic kids carry some risk of cerebral edema.
And there's not a strong need for emergent administration in a normotensive child. Providers may still use fluids for pediatric hypotension or shock.
Protocol 46, Psychiatric Emergencies. Providers are reminded about the importance of de-escalation. Restraint should only be used to increase patient safety, and only when the benefit outweighs the risks.
It is also an OEMS red dot skill, so we wanted to review patient restraint medication. If you have any questions or if you're a new provider, contact your training officer.
Trauma code has also been updated to reflect the change to amiodarone and to match medical code.
The workgroup also wants to emphasize the idea of balanced resuscitation in hemorrhagic shock. This has always been true, but the concept deserves special focus.
Providers should target a systolic blood pressure of no more than 90 if they suspect hemorrhagic shock. Pushing a blood pressure higher than 90 in patients with significant trauma may lead to some increased blood loss, over-resuscitation, and dilution of clotting factors. So we'd prefer to keep a balanced resuscitation with a systolic of no more than 90.
Providers should target higher systolic blood pressures for isolated head or spine injuries or for pregnant trauma patients. In Protocol 56, Major Trauma, the indications for ANSEF have been increased.
It is still appropriate to give if you suspect an open fracture.
But now providers can administer ANSEF for any major open wound.
So if a major trauma patient has a significant open wound or an open fracture, please consider giving ANSEF.
In number 58 bleeding, the dose of TXA has been increased to 2 grams.
On the advice of our trauma colleagues, it is still recommended to give it over 10 minutes.
Lastly, we'd like to finish up with a reminder about the critical care program.
Critical care protocols are for specifically trained and credentialed paramedics only. Providers must be cleared by your agency and maintain all prerequisites.
It's really meant for agencies that can commit to increased time and the expense for equipment and drugs.
Regional in-service trainings are ongoing. If you are an interested agency, you should reach out to the Western Virginia EMS office for more information.
There are several critical care updates that will be covered more in depth during the in-service, but they include removal of succinylcholine in consideration for DSI. Also, you'll notice a new regional blood protocol.
Finger thoracostomy has been added as a salvage technique for trauma.
Also, expanded sections on RSI prep, checklists, and vent titration.
All right, final steps. So that's it. To finish the process, you should download and print the attestation,
sign it and turn it into your training officer,
and then wait to be formally released to start using the new 2025 version. Thank you all for your time and dedication. And finally, a quick note that the region is committing to a more regular release schedule for the protocols, so look for all future protocol updates to drop every January from now on. See you in 2026.